This is Dr. Jason Lee, clinical immunologist and allergist. Welcome to Lecture 4. In this lecture, I'm going to be talking about treatments for asthma, and I'm going to take a historical perspective as well as an evidence-based perspective. It's important to remember the history because it reinforces some of our biologic understanding. Before the advent of modern medicine, all we could really do is suggest a change of scenery. If you're exposed to a lot of smoke, you don't work with smoke anymore. If you're allergic to dust, you try to keep your place tidy. If you're so fortunate, you could actually be sent to the Swiss Alps, where above a certain altitude, there are no longer dust mites present and living. Fast forward a few more years, the discovery of coffee. Coffee may decrease mucus production and relax your smooth muscles. As such, it has a small benefit. There's a compound called theophylline, which mimics the effect or mechanism of coffee. This is by something called manipulation of cyclic AMP. Cyclic AMP have the similar effects of caffeine. Now, as you can imagine, these are only modestly helpful. Later on, antihistamines were discovered. These work for asthma because eosinophils and mast cells produce histamine. Histamine is one of the major inflammatory chemicals that get released from these cells to cause inflammation. One step further is drugs like ketotifen and cromolyn. These are known as mast cell stabilizer antihistamine combination medications. Not only do they block histamine effects, they also prevent the cell from activating in the first place. This is what we mean by membrane stabilizer. The cell itself can no longer activate or turn on, aka spew its contents. If the contents don't get released, there's less inflammation. Now, later on in the 70s, inhaled corticosteroids gradually started taking over. It became abundantly clear by the 80s and 90s that inhaled corticosteroids are far superior than any previously known treatment. Why? Well, there's evidence that enables normal activity and exercise and quality of life. It eliminates or reduces chronic symptoms of asthma. It prevents exacerbations, reduces the need for rescue beta agonist medications. So these are things like Ventolin and Bricanyl. We also refer to these as SABAs, or short-acting beta agonists. It also reduces hospitalizations, asthma death rate, and maximizes lung function over decades. Now, patients will always ask you, I don't want to take steroids because steroids are bad. It's important to emphasize that the body naturally produces approximately 7.5 milligram equivalents of corticosteroids on a daily basis, quote unquote, naturally. Asthma inhalers are in microgram quantities. Really, with one exacerbation requiring prednisone for approximately 1 week, this is way more steroids over a given year than taking inhaled steroids on a daily basis. If you really hate steroids, you should take inhaled steroids because you would be reducing your chance of requiring a doubling of your dose of steroid. The next step up in most asthma guidelines from inhaled steroids when you don't get enough or not enough of the desired effect is to use something called a combination inhaler. These are typically combinations of steroids and beta agonists. You would think that using one after the other would be similar. However, this is not the case. One of the trials that showed this, Canadian trial here, is Chapman's study in 1999. This showed that you get more of a benefit with a combination inhaler above and beyond using one after the other. Another trial that showed much significant benefit with combination inhaler was the Optima trials. This showed that addition of formoterol to budesonide reduced the first exacerbation by 43%. This is more than doubling the inhaled steroid alone. Now, this is largely adult data, I'd like to emphasize. Some pediatric evidence suggests that the first step is to actually double the dose of inhaled steroid rather than adding a combination inhaler. I just want to point out that nuance in case people are unclear. There are many ICSs available in Canada for adults and children. This includes beclomethasone, budesonide, fluticasone, ciclesonide, and now mometasone. Combination inhalers include Zenhale, Advair, and Symbicort. Symbicort also has another indication to be used as both a controller medication and the rescue. There are multiple mechanisms of action of steroids. Suffice it to say, though, or to summarize, is that steroids diminish the activity of all immune cells that were previously discussed. This also explains some of the common side effects that patients can experience. For example, oral thrush. This is a proliferation of fungus growing on your tongue. Even if you use the perfect inhaler technique, it is possible to get a lot of the inhaled steroid coated on your tongue. Because there is a suppression of the local immune response there, it is possible to have opportunistic organisms such as fungus start proliferating. That is why it is very important to rinse out your mouth after using your asthma inhaler. The lung is generally a sterile cavity, and as such, you don't run into this side effect. As you remember in the asthma histopathology, there are many layers in the asthma airway and many opportunities to intervene with medication. It is important to note that asthma is a chronic condition with acute flares. Structural modifications occur over time if the asthma is not controlled, and the acute inflammatory events, such as from infections, will accelerate this for that period of time. Over a lifetime, a patient with asthma will have a decline in their lung function greater than that of the average person. Everyone's lung function declines, but if you have uncontrolled asthma, it will decline faster. Other side effects, such as on bone, are in fact real. Decreased height, velocity, and now it appears final height by roughly 1 centimeters or so seems to be a real effect in children. However, the consequence of having an asthma exacerbation again, I would emphasize, are far worse. The same advice applies to pregnant patients. Many pregnant patients are averse to taking any medications during pregnancy. However, the risks of not controlling asthma are far greater than the risks from inhaled steroids. It is important to have a discussion with a healthcare professional on whether or not an intervention is right for you. Other side effects such as adrenal suppression, adrenal fatigue, adrenal crisis are extremely rare with inhaled steroids. The last category of interventions that I'd like to state is allergen immunotherapy. Allergen immunotherapy works by manipulating the immune system and retraining the immune system. I will talk about this more in Lecture 6, as it is the oldest biologic known for the treatment of asthma. That is all for this lecture.